Hello everyone. In this video, we will talk about antifungal group of drugs. First of all, let us start with the classification of all the antifungals. So antifungals can be divided into the following different classes. The first class is antimetabolites, under which we have the drug flucytosine. So antimetabolite has flucytosine. Allylamine has the drug terbinafine. Then we have topical agents like tolnaftate, tavaborole, undecylenic acid, and butanafine. These are topical agents, which means they are drugs used topically. Tolnaftate, tavaborole, undecylenic acid, and butanafine. Next, we have azoles, which is a very important class of drug, one of the most important class of antifungals, under which we have imidazoles and thiazoles. Under imidazoles, we have clotrimazole, meconazole, and ketoconazole. And under triazoles, we have fluconazole, itraconazole, voriconazole, and posaconazole. These are the azole group of drugs, imidazoles and triazoles. Then we have antibiotics. Antibiotics include the group polyenes, under which we have amphotericin B, another very important antifungal drug, and nystatin. Then we have echinocandins like caspofungin, micafungin, and anidulafungin. Finally, we have heterocycle benzofuran called griseofulvin. So this is the basic classification of all antifungal drugs. Antimetabolite is flucytosine. Allylamine is terbinafine. Topical agents like tolnaftate, tavaborole, undecylenic acid, and butanafine. Azoles, all of those drugs will end with the word azole, which is imidazole and triazoles. So you have clotrimazole, meconazole, ketoconazole, and then fluconazole, itraconazole, voriconazole, posaconazole. Then we have antibiotics like amphotericin B and nystatin. Under echinocandins, we have caspofungin, micafungin, and anidulafungin. Under heterocyclic benzofuran, we have griseofulvin. Now let us classify each of these drugs based on their mechanism of action. For that, I will explain this to you using a diagram of a fungal cell. So let us assume this is the cell wall, this is the cell membrane, and this is the nucleus containing the DNA. The first group of drugs that we will talk about is echinocandins. So echinocandins are cell wall synthesis inhibitors. In the fungal cell wall, there is one very important component called beta-1,3-D glucan, and that is formed by the enzyme known as beta-glucan synthase. The next group of drug is griseofulvin. Griseofulvin is a microtubule inhibitor. We know that microtubules are important for cell division. So since griseofulvin will inhibit microtubule assembly, they will eventually inhibit division of the fungal cell and will lead to inhibition of the infection caused by the fungus. The next drug is flucytosine. Flucytosine is a DNA inhibitor. Now flucytosine is a prodrug, and in our body it gets converted into 5-fluorouracil. 5-fluorouracil is an antimetabolite which gets incorporated into the DNA of the fungal cell. Now this is not a naturally occurring nucleotide in the DNA, so it will lead to defective DNA synthesis and eventually leading to lysis of the fungal cell. So that is how flucytosine acts, by inhibiting DNA synthesis and causing defective DNA synthesis. The next group of drugs are cell membrane inhibitors. Fungal cell membrane has something called ergosterol, which is a very important component of the cell membrane. And the starting point of formation of this ergosterol is by squalene. In the normal formation of the cell membrane, squalene gets converted to squalene epoxide, which through multiple steps gets converted into lanosterol, and lanosterol finally gets converted into ergosterol. So this is the process of formation of the cell membrane: squalene, squalene epoxide, lanosterol, and ergosterol. Now The drug terbinafine inhibits the enzyme squalene epoxidase. Squalene epoxidase is the enzyme which is required to convert squalene to squalene epoxide, and because terbinafine inhibits this enzyme, this step will not happen, which inhibits the cell membrane formation. Similarly, azoles act by inhibiting the conversion of lanosterol to ergosterol, eventually inhibiting cell membrane synthesis. So both terbinafine and azoles work in this process of formation of the cell membrane, especially the cell membrane component ergosterol. They will both inhibit the formation of ergosterol by different processes, and eventually they will inhibit the cell membrane synthesis. Finally, amphotericin B will work by forming pores in the fungal cell membrane. So it will form pores which will lead to leaking out of ions and amino acids from the fungal cell and eventually lead to fungal cell death. So amphotericin B also acts on the cell membrane by forming pores in it. As you can see in the diagram, it will form a sort of a pore, and amino acids and important ions will leak out from the cell, and it will eventually cause fungal cell death. In the side effects for echinocandins, we could have minor side effects like rash, little bit of dyspnea or hypokalemia, but they are mostly well tolerated. For terbinafine, we can have hepatotoxicity and Stevens-Johnson syndrome. For azoles, we have a lot of hormonal side effects like menstrual abnormalities in females, oligozoospermia in males, and then we have a lot of GI symptoms like nausea, abdominal pain, and loss of appetite. Apart from that, we can also have alopecia and gynecomastia. Amphotericin B is also quite a toxic drug. It causes hypokalemia, hypomagnesemia, acidosis, anemia, and it is a highly nephrotoxic drug. So this is the main side effect. It is a highly nephrotoxic drug. So whenever amphotericin B is given, we definitely have to give fluid during and before giving the drug so that the kidney remains protected. And there could be acute side effects as well, like chills, fever, and body aches. So right after giving the drug, the patient might experience these side effects. For flucytosine, we can have side effects like bone marrow suppression. Since we know flucytosine is a DNA inhibitor, it can inhibit the formation of cells from the bone marrow as well, causing bone marrow suppression. Apart from that, we can also have GI symptoms. Finally, griseofulvin can cause headache, gastrointestinal symptoms, CNS symptoms, hepatotoxicity, and rashes. Now let us look at the spectrum of all of these drugs. So the widest spectrum drugs are azoles, and in that we have different drugs which are used for different infections. So clotrimazole will be used for oral or vaginal candidiasis as a topical preparation. Fluconazole will be used for cryptococcal meningitis, coccidioidal meningitis, and candida infections. So mostly all of the candida infections we give fluconazole as the drug, especially in candida albicans, because it is sensitive to fluconazole. So fluconazole is used as a drug of choice. Itraconazole is used as the drug of choice for all systemic mycosis, which is your histoplasmosis, blastomycosis, coccidioidomycosis. Then it can also be given for dermatophytes, sporotrichosis, and aspergillosis, especially the allergic bronchopulmonary aspergillosis. So for ABPA, we give itraconazole, but for the invasive forms of aspergillosis, we will give drugs like voriconazole, which is the main drug, posaconazole or isavuconazole. For ABPA, we have itraconazole, but for the invasive forms, we have voriconazole, posaconazole, and isavuconazole. So this is the spectrum of azoles. Then we come to a drug called amphotericin B. Amphotericin B is used in candida meningitis. So if candida infection is causing a meningitis, we give amphotericin B in that case. Amphotericin B is also the drug of choice for cryptococcal meningitis, and it is the drug of choice for mucormycosis. Flucytosine is used along with amphotericin B in cryptococcal meningitis. That is the drug of choice. Griseofulvin is used for dermatophytes, which is your tinea infections. Echinocandins are the drug of choice for non-albicans candida. So Candida albicans has a good sensitivity for fluconazole. So that is the drug of choice for Candida albicans. But non-albicans candida are resistant to azoles. That is why we give the drug group echinocandins in a non-albicans candida infection. This is the drug of choice in this case. Apart from that, it can be given as second line in Candida albicans as well, and then it can be given for aspergillosis. Finally, terbinafine is given in dermatophyte infection.